I do that, I'd just like to let people know that the presentations will be available via our website, linking into other people's, apart from Julie's, because it's not available publicly as yet. But the others will be on there, we're hoping within the next couple of weeks. So, because there's been so much information that we've heard today, I'm sure everybody will want to see that. So I think what we'll do is, if you have a comment or a question to a particular panellist, if you just raise your hand, and I'll try and manage that. We'll try and, I don't know how we're going to manage this in 20 minutes. Mind you, you might not say anything, so... So can we open up the floor now? If you would like to put your hand up to make a comment or ask a question to a specific member of the panel, then now is the time. Jane, yes.
I'd just like to thank Aoife, Susan, everyone. This is fantastic to have this opportunity to get such amazing diversity, but also quite a lot of overlap between people's views. I work at the University of Greenwich, and our job is to prepare speech and language therapists to go out and work. We did a similar sort of day just recently on autism and SLI. We set up a debate, and I did a role play of a difficult consultant paediatrician. And anyway, it was quite exciting to try and sort of tackle this problem. I would love to hear your advice about how to prepare speech and language therapy students and newly qualified. This is a huge and complicated area. What are we meant to be preparing them for, and how?
Anybody
They
like
can read all your stuff. They can read all your stuff. They can read Tomlin. They can read, and they can try. Any just little tips of advice.
Well, I guess it depends on where they go for placements. I mean, I don't know what placements are like these days, or how it's changed, but I guess it's the thing about differential diagnosis. And if you go into a clinical placement, are they actually doing differential diagnosis? When I did my training, we had like 15 minutes to see people. You don't have any time to do that or think about it in any serious way at all. So I guess it would be looking for red flags, I would say, and knowing when to refer on to the more multidisciplinary teams. And
I agree. I think a big problem is that we are trained diagnosticians. It's one of the things when we went through Agenda for Change that we said we're special because we do diagnosis. Yes. And I'm very anxious, and David and I talked about this, that we are downgrading our profession because we're not doing differential diagnosis. So that's partly why I was so provocative, because one of the reasons we're not doing differential diagnosis is because I think the health service management structure, or whatever it is, I don't want to get too political, are saying don't bother. There isn't time for it. And anyway, actually, are we providing a differential diagnosis that leads to a differential provision?
Sure.
But I think if we want to take it from a purely selfish point of view, if we don't, what value do we add over any other early years worker? And actually, in terms of, because there are a lot of people out there who are good at assessing children, and they're good at
So we have to get them good as diagnosticians.
But we have to remember, yes, diagnostics is part of what we do.
Yeah.
And I think we are autonomous clinicians, and we have to, you wouldn't be saying to a doctor, don't bother to do a differential diagnosis. So why are we so amenable to being pushed into not doing our job properly?
Thank you.
Karen Gavin, CEO at the Royal College of Speech and Language Therapists. Well, I think, Vicky, you've hit on something that's really concerning, and certainly when we talk to government about the value of AHPs as a whole, including speech therapists, we do talk about the fact you're autonomous practitioners and that you do differential diagnosis. If you're being told not to do that, that's actually an issue we then need to pick up. And we need to look at how we support you locally with talking to commissioners. You're absolutely right, we keep saying, well, if it was a doctor, you wouldn't say to a doctor, including in intervention terms, you wouldn't say to a doctor, oh, just take out half a hip, you can't afford a whole one, or we'll give you a prescription for a medicine that we know doesn't work. So why are we saying we'll give you 6 blocks of therapy when we know that's actually not evidence-based? And I think we're moving into a climate where commissioners are going to be commissioning on evidence-based practice. That's your lever. our worry is that we need our members to look at the evidence base and to push back, so we can work with you and empower you. But you know, it's using all the resources that are there in your hands and letting us know what the barriers are.
I think just to really specifically answer your question, I think one thing students could learn to do a lot better is just observation and forming an initial hypothesis about where to go. So that grid Vicky showed with all the possible things. So if you're just looking at a child for 15 minutes, where are you going to go next? And honing those observational skills will be really useful.
Yes.
Yeah, I mean, this isn't political in the slightest, but I manage a team of 13 therapists that provide service to mainstream schools. And in terms of using skill mix, we use teaching assistants in the school. We have a great team of assistants that will offer therapy. And in terms of our capacity, we're also going to be able to ourselves start offering therapy in mainstream schools from the therapists. And my question is, how would you, in terms of criteria for which children access the package from an assistant and which children access a package from a therapist, which is what we're looking at the moment, what advice would you give in terms of criteria, really? Because we have to be very, very clear about parental expectation and the messages we're giving.
Well, can I just point you to Claudine, because in all the York stuff you have trained the assistants to do it, but you supervise them quite closely, right?
We've trained the teaching assistants to deliver the interventions. We've selected the children, so we haven't actually left that up to them. And I don't know whether I'm not a speech and language therapist, haven't got that background. So, but I would assume that teaching assistants wouldn't have the knowledge to actually make those decisions about which intervention, whether the children should have a teaching assistant.
There is some research as well that shows that actually children that get a package from a teaching assistant or a package from a speech and language therapy assistant do better with the intervention from a speech and language therapy assistant. My concern is more which children get the therapist as opposed to the speech and language therapy assistant, and what criteria do you use? Do you say it's about scores on standard tests? Do you say it's about diagnosis? Do you say it's about, is it functional? I mean, it's just those criteria
to do.
Because
I think you're doing an oral language program that's very heavily focused on vocabulary, and the assistants are quite successful at delivering it if they have a lot of support. But there might be other aspects of language where you do need that specialist training.
I think that's true, and I think they did need a lot of support for carrying out the interventions. And what we didn't specify when we recruited our teaching assistants was any kind of criteria that they had to meet in order to deliver the intervention. And so there was a lot of difference in terms of their own language abilities, if you like. So they did need a lot of support. And I think it is a complex area, and unless you're really well trained and you're dealing with children with complex needs, I don't think you can make those decisions by yourself. I think the speech and language therapists.
Right, Susan?
Sorry, I just wanted to say that I'm not sure that it's necessarily, sort of what Courtney is saying, that it's necessarily the child that will dictate who gives it. It might be the area you want to target, because if you've got a very well-defined programme, then an assistant may carry it out equally as well. A fairly contained, simple area of language where you know exactly what the child needs and you know how to do it, you can then give that to an assistant and explain it and support them. Other areas takes a lot more, there's a less well-defined package, it's much more complicated, it needs much more clinical decision-making as you go along. So I think it might not depend on the child, but more on the area of language that you're working on.
Could I just like to say, I think there's a sort of fundamental issue here, and that is that and we need to think about Elspeth McCartney's work, which is I think what you were referring to when you were saying if it was delivered by school-based professionals, it wasn't maintained, and that's not because they weren't necessarily good at doing it, it's because it wasn't being delivered. And I think I have many bugbears, and one of them is that we as a profession ask teachers to deliver things that are outside the national curriculum, and then we're a bit surprised when they haven't had time to do it. And I think that's our fault. So I would also agree that I don't think it's necessarily around the child. I think it's around what type of thing you're trying to deliver. So if it's support around the literacy curriculum, and it is part of the literacy curriculum, with adequate training, I think it's quite easy. It would be more successful to ask school-based professionals to do it. If it's outside that, first of all, I would wonder why we were doing something outside the curriculum. I mean, my heart sinks when I see a speech therapy report that says this child needs to work on prepositions, because you kind of think, well, that came from the assessment, but how does that fit into your geography, history, whatever else? So that's something we need to address. And then when we're working with school-based staff, we have to see, is this taking this person right out of their school comfort zone and the curriculum, and you know, how sensible is it for that person to be delivering it? If it's a very different programme, then I think we probably shouldn't be asking school staff to deliver it.
Can I just say something else about that? Our programme was very, very prescribed. It was literally, each session was to the point where we sort of like, say this, say that. I mean, they literally had to pick it up and take it, and they had the materials and everything. Saying that, our teaching assistants did a fantastic job, and they really did, with the training and support, they really did step up to the plate and deliver the intervention. But they were very well supported, and we controlled it, we monitored treatment fidelity, we observed their practice, so we were you know, hands-on with the intervention. But the other thing is, as you say, Vicky, time was an issue, and often we would find that some sessions hadn't been delivered, or they were at different stages because they're not able to be released from their classroom duties. And I think that's, you know, the pressure on the teaching assistants in the schools to deliver those interventions on top of what they're already doing is sometimes too much, and they're just pulled off them, and the children don't get the intervention.
We've probably got about 5 minutes left to discuss sort of what, if anybody wants to raise any issues about SLI and all the stuff we've heard this morning. Packages
that just people have been mentioning. So we have details for our 162 children, and we have reports from the SENCOs in terms of the financial, what packages they buy in, and we have the observations that were done in the classrooms in terms of what packages were used, and we have the teachers' reports of what packages, and it's all pretty consistent, and the answer is virtually none. So I think the SENCOs costed in across different schools 6 packages. One of them you already know, which is toe by toe. There was one special computer package. So I think we have to think about, when we're talking about it, what's actually happening in the classroom for children. So that's just why I raised the package issue.
So I don't know if you...
Thank you. Helen Derwent. I work here in East Surrey, East locality. Just wanted to go back to the definition of SLI. And when I came out of university, I had it clear in my mind what I thought the general sort of agreed definition was in terms of non-verbal IQ and the disparity with the language levels. And then I was shocked to hear from the educational psychologists that they don't like doing the non-verbal IQ tests. They didn't feel it was productive. They didn't feel it helped them in supporting the children. And I did kind of just wonder where that left speech and language therapists, because we are by and large relying on other professionals to do their non-verbal testing. So anyway, I just wanted to throw that out there, because you know, I just maybe naively thought that I was going to have available some non-verbal IQ tests to help me with my diagnosis. So
I think it's quite political. There are some psychologists who actually, you know, in principle